We'll be discussing about Plummer-Vinson syndrome. Plummer-Vinson syndrome has a classic triad of dysphagia, that is post-cricoid dysphagia, iron deficiency anemia, and also known as sideropenia, and esophageal webs, upper esophageal webs, which is mostly seen in females because the females are more susceptible to develop iron deficiency anemia in our country. So usually females around the age of 40 years. It is also seen in young adults and adolescent girls also. So if a female who is having a pallor presents with dysphagia, you should also always have Plummer-Vinson syndrome in your mind. What is the etiopathogenesis? So as the triad goes, there is iron deficiency anemia. So the patient is having iron deficiency. It can be due to some nutritional cause, or the patient may be having some minor blood loss, continuous blood loss for a prolonged period of time, menorrhagia, or some gastric ulcer that is bleeding, etc. Then associated B vitamin deficiency is also there. Then other etiology include genetic predisposition and autoimmunity. So patients with Plummer-Vinson syndrome are found to have other autoimmune diseases like pernicious anemia, thyroid nodules, so autoimmune thyroid disorders, celiac disease, Crohn's disease, etc. So autoimmunity also plays a role in the development of Plummer-Vinson syndrome. So the main cause is iron deficiency. So there are many enzymes in our body that require iron for functioning, mainly redox reactions, that is oxidation reduction reactions. Many catalases, cytochrome, hydroxylases, glycolases all require iron. So when there is iron deficiency, there is malfunctioning of the iron requiring enzymes, and there will be oxidative stress, DNA damage, etc. And when this malfunction occurs, what happens? There will be recurrent epithelial injury. The mucosa of the oral cavity and the esophagus are very sensitive, and recurrent esophageal injury causes the epithelium to react by atrophy and web formation. Also, there is myasthenia of the esophageal muscle. So the amplitude of contraction of the esophageal muscle reduces. So the patient will have reduced esophageal motility also. And the maximum stress occurs at the region of the post-cricoid area when you are swallowing. So the web formation occurs at the post-cricoid area. So there is improper healing of the epithelial mucosa, atrophy and web formation. Also, esophageal motility is affected. Most commonly, the esophageal web is located below the post-cricoid muscle, and it will be asymmetrically attached to the anterior wall of the upper esophagus. That is the most common location. So the web is usually composed of a thin mucous membrane that is composed of squamous epithelium. If you take a biopsy and see histopathologically, there will be fibrosis, epithelial atrophy, hyperkeratosis, and basal cell hyperplasia, and small amounts of chronic inflammatory infiltrates. What is the clinical presentation? Usually the patient presents with difficulty in swallowing. The difficulty in swallowing can be intermittent. So initially it will be intermittent and gradually progressive. Patient will not say typically pain during swallowing. Patient will complain of discomfort during swallowing. Patient will complain like something is sticking to the throat while swallowing. Difficulty in swallowing solids than liquids. So it can be divided into two grades. Grade 1 is patient coming with intermittent dysphagia, difficulty in swallowing solids. Grade 2 is patient is able to swallow semi-solid food only. Sometimes patient will say there is coughing and choking episodes because of the post-cricoid web and obstruction to the swallowing. The patient will develop typical swallowing deficiency only if the esophageal diameter, lumen diameter at the level of the web is less than 12 millimeter. Patient will also have symptoms of iron deficiency like chronic fatigue, lethargy, lightheadedness, dizziness, etc. What are the clinical findings? Patient will have pallor, angular cheilitis, glossitis, atrophic glossitis. Some patients can have splenomegaly, thyroid nodules. Some patients have loss of teeth due to chronic gastroesophageal reflux. What are the investigations that can be done? We have to do a complete blood count, hemoglobin, peripheral blood smear. Then you have to do iron studies, serum iron, total iron binding capacity, serum ferritin, serum transferrin, etc., which helps you to identify the level of iron deficiency. So to investigate the dysphagia, you can do a barium swallow. Barium swallow will detect any upper esophageal webs. Also, you can do a video fluoroscopy that also will detect the webs. An upper GI endoscopy can be performed. The esophageal web is seen as a smooth, thin grey lesion with a normal appearing mucosa with a central or lateral lumen mostly attached to the anterior esophageal wall. Also, upper GI endoscopy helps you differentiate a differential diagnosis. Like the differential diagnosis are there can be any inflammation or infective strictures, any post-cricoid malignancies, any external compression from submucous venous plexus, or if there is any esophageal rings, any heterotopic gastric mucosa, that is the gastric mucosa is located on the upper esophagus, that is known as inlet patch causing stricture. Also during gastroendoscopy, you can rule out any cause of iron deficiency like any diaphragmatic hernia with erosions, any other gastric erosions causing bleeding, any gastric ulcers causing bleeding, Crohn's disease, presence of celiac disease, all this can be evaluated using a upper GA and lower GA endoscopy. What is the treatment? The treatment is medical and surgical. So medical treatment is supplementing iron. So iron supplements can be given oral, and IV supplements also can be given. Many patients may not tolerate iron orally, and also oral absorption of iron can be reduced. So you can give IV iron supplements also. In early dysphagia and minor webs, iron supplement itself will reduce the dysphagia. And as iron improves, the dysphagia is completely cleared. But in severe cases, you have to do a mechanical dilatation of the esophagus. The rigid esophagoscopy is actually diagnostic and therapeutic. Like just the insertion of the rigid esophagoscope may reduce the web and the esophageal constriction, and the patient will get better after the esophagoscopy. You can also use a boogie to dilate the esophagus. Also, there are other surgical excision of the esophageal web using laser, Nd:YAG laser, and also techniques like needle knife electron incision. The prognosis is usually good prognosis. If detected early with iron supplements itself, the patient will improve. But if not detected early and if not treated properly, it can progress to absolute dysphagia, and patient can develop aspiration pneumonia. Other complications are while doing an esophageal dilatation, while a esophagoscopy, there's a chance of perforation of the esophagus, which is a serious condition and has to be repaired immediately. Another one important complication is patients with Plummer-Vinson syndrome have a tendency to develop squamous cell carcinoma of the hypopharynx and upper esophagus. So this has to be kept in mind, and patient has to be on proper follow-up. The problem is once we correct the anemia and the patient goes home, again the patient will develop anemia and same symptoms. I have seen patients like that, 2-3 episodes they will have. So such patients are at a risk of developing squamous cell carcinoma. So patient has to be counseled that there's a chance of developing cancer if this is continuing. They have to be given diet and nutrition counseling, and they are advised to take iron-rich diet. Also, iron supplements has to be given, and they have to be kept on proper follow-up. Post-cricoid dysphagia, iron deficiency anemia, and upper esophageal webs. Mostly the treatment is you can give iron supplement and dilatation if required.